This is a case of laparoscopic management of ruptured hemorrhagic cyst and umbilical hernia repair. Hello friends, this is a costal margin and this is the mid clavicular line and 3 centimeter below the mid clavicular line this is the Palmer's point and 2 centimeter above the costal margin this is the Mishra's point. So basically what is Mishra's point is the stretched Palmer point. So we will stretch it down and bring this abdominal wall below the costal margin. And after surgery, once we will remove the gas, then again it will go over the rib. So it is basically a stretched Palmer point, and after hemoperitoneum it will remain stretched down. So the advantage of this point is that you don't need port closure and there is no chances of adhesion anterior to the rib. So this is suction, irrigation and hanging drop test. And after that we will create hemoperitoneum. So I will tell you about this case. This patient has a ruptured hemorrhagic cyst and there is a umbilical hernia. You can see the bulge of the umbilical hernia is visible and she has a 6 centimeter hemorrhagic cyst which got ruptured. So after this rupture of the cyst there is a blood collected, approximately 1 liter blood is collected in the abdominal cavity. So first we will do the thorough suction irrigation, removal of the cystic wall and thorough lavage of the abdominal cavity, and after that we will do the primary closure with the barb proline suture for the umbilical hernia. Because in these cases where you have the blood collected and this was collected 4 or 5 days before, patient has delayed it. So in those situations peritonitis is already started. So we will not use mesh, we will do primary closure of umbilical hernia. So now this is the trocar which is introduced in the Mishra's point, and it should be pointed towards the stomach and nasogastric tube is essential. So this is now telescope is introduced and then this is the another port that we have put at the level of umbilicus, so that we can perform both the surgery, the pelvic surgery, that is the gynae surgery of the vas of the ruptured hemorrhagic cyst, and we will also perform the hernia surgery. So these are the 5 mm port, and once we have put the telescope we have seen already blood inside the abdomen and hemoperitoneum was found. So this is the second port and now patient head will be down and this is a diagnostic laparoscopy is being performed, and then this is the third port will be introduced. You can see the bulge of the umbilical hernia is also clearly visible. So now this is moving all the bowel and doing the diagnostic to find out, and this is the third port. So we have found that there was right hemorrhagic cyst which was ruptured and the blood was collected all over abdomen. Maximum amount of blood was there in the pelvis, in the posterior cul-de-sac, but a lot of blood was in the Morrison's pouch also and subdiaphragmatic area. So this is the second working port. So we have 2 ipsilateral ports, and now we will show you the vision of the laparoscopy. So inside the abdomen, and we are moving the, and we have seen in the umbilical hernia there is adhesion and little omental content is there. So with the finger you have to push, with the left finger you have to push all the content of the umbilical hernia down in the abdomen, and these all omentum should be separated and the content should be taken out, and this all adhesion of the omentum is cleared. The blood which you are seeing over the omentum, on the anterior abdominal wall, these all are due to the rupture hemorrhagic cyst. So, here we can see this is the bare skin and there is no content in the hernia sac now. So, before repairing the hernia, first we will do the examination of the ovary and we will check that which ovary was ruptured. So, now we can see this all the small bowel is moved up, sigmoid colon is pushed towards the left and we can see huge amount of the blood is in the pelvis, and this look like a dark blood because it was ruptured 3-4 days ago and a lot of clot is in the pelvis. And this is the ovary which was ruptured and this is the part of the ovarian cyst is still visible, and there is a clot in the cul-de-sac and the blood is in the abdomen. So, first thing what we will do, this is the left ovary which is fine, and this is the right ovary and this is the rupture part, and after rupturing it is a small, now cyst is a small, but before rupturing it would have must be bigger one. So, what we will do that we will remove that part of the cyst, and for that holding with the harmonic, this is ovarian ligament and this is the cystic wall, and with the harmonic we will cut out the cyst. So, this is cystic part of the ovary is resected out, and there is no endometriosis, this was just a hemorrhagic cyst. So, after that we will do some ovarian drilling to check that is there any other cystic pocket. So, there was nothing. And clear fluid is coming, these are follicles. After that we will suck all the clot which is in the cul-de-sac. So, this is the suction and these clots are, we are trying to liquefy the clot and suck it. But sometime 5 suction may not be able to suck all the clots in spite of breaking it in the small pieces. So, in that situation it is better to use 10 So, we are telling our nurse to prepare the 10 suction. Irrigating also with the 5 can help. So, this is irrigating and then sucking, but still the clots are organized. So, now we have a 10 here and this 10 is sucking all the clots nicely, and this cyst was also sucked out. After that again irrigation, again suction. And now the cul-de-sac is almost clear, but a lot of blood is in the bowel loop and all around the abdominal cavity. So, we will do thorough lavage, 3 liter of the saline was used 2-3 times to do thorough lavage, and dilution is the best method of removing these bloods. So, you can dilute it and then again suck it in the cul-de-sac, anterior as well as posterior. So, now this is anterior cul-de-sac and all the fluid was sucked in this area. Now, it looks clean. Then we will clean the other part of the abdomen. This is paracolic gutter, then the bowel loop, right iliac fossa, splenic fossa, diaphragmatic area, Morrison's pouch, everywhere. We can see this is the right iliac fossa has some adhesion. We do not know why this adhesion is there. This is looking like an old adhesion. This is ileum, this is adhered, this area. You want to see appendix, this is appendix, appendix is normal. Appendix is not a problem. So, now this is the hepatic flexor of colon, transverse colon, gallbladder is normal. So, this irrigation thorough lavage is required, because if you leave the blood there will be peritonitis. And now we will do the barb suture. This is barb proline, and we will do the primary closure of this hernia. So, we are starting with the healthy margin and then 1 centimeter at least lateral to the margin, out to in and in to out. Full thickness bite will be taken, and then we have already made a loop, bigger loop outside. However, barb has already a smaller loop, but passing the suture through the smaller loop is sometimes difficult. So, you may make a bigger loop, passing the needle outside itself in the bigger loop, and then pulling the needle out from the loop, and then it will be tightened the barb suture. So, barb suture is very useful for repairing the defect, doing the primary closure or doing the IPOM plus also, because once you stretch and approximate the rectus margin, after that it does not return back, it remain in the same position. If you will take full thickness, you should take as much muscle, and full thickness rectus also should be taken. So, you can see after tightening, we have not decreased the gas is same 15 millimeter mercury, but after tightening the suture it is not returning back. So, thanks to this proline barb, that approximation of the hernia is very easy, very secure, and you can see defect is already closed. But we will return back, we will take double layer. In barb suture you should not lock it also, locking is not required, because already it has a projection of the barb. So, locking is not good. So, this is we are returning back to reinforce this suture margin much better, and that will give extra strength, because we are not using mesh. So, it is better to do like a crisscross. Suturing in the anterior abdominal wall is very easy by the Da Vinci robot. In the laparoscopy, little difficult, because you have to take a reverse bite and properly you have to rotate the needle. So, it is reached to the healthy area again, and after that we will take a bite on the healthy tissue and we will terminate it by the Aberdeen termination. So, to do Aberdeen termination, you should make a loop and you should go loop within loop and then pull the non needle end. It get locked. Again pull the needle end and again pull loop within loop. This is loop within loop, and again you should pull the non needle end and it get double lock, and then finally go through the loop and take the needle out. So, this is very good termination. Otherwise, termination may not be required in the barb suture, but we always terminate by Aberdeen. And now you will cut the suture near the needle, because if you do not want to terminate, you have to keep that tip better big. But if you will do Aberdeen, you can cut it small. This is over. After that, we will remove this barb suture through the wound and then little suction in the cul-de-sac, anterior cul-de-sac. And after that, we will put a drain also. So, here we are using the nasogastric tube as a drain, and you can use the knot pusher, Van Darker knot pusher, to introduce the drain inside. But this 10 port which we have used for the 10 suction, that is good to close, because otherwise chances of hernia will be there. So, because any 10 port which is in the lateral you should close, but Palmer's point also you should close, but Mishra's point not required to close. Now, this is one darker knot pusher with the NG tube, and you will put it into the eye, and once you go to the cul-de-sac, rotate the knot pusher to anti-clockwise and it will leave the drain and knot pusher will come out. So, this is done and surgery is over. So, thank you very much for watching this video. This was just a simple case of management of the ruptured hemorrhagic cyst and together with the umbilical hernia repair. Thank you very much. Have a nice day.